Good morning, everyone. So, today we're gonna do trauma. We're gonna study about trauma, and trauma, we all know it's a part of surgery and it's a very important topic as a part of emergency management, also. So, there are two ways which we can divide studying it, like how we'll do whenever a trauma occurs. What will you do? You'll have a primary survey that tells you about all the potential injuries and what interventions have to be taken, and then there is a secondary survey. This we do after the primary survey is complete and the patient is stable, and then we do head to do all the examination and evaluate all the organ systems. So in primary survey, mainly there is airway, breathing, circulation, disability, and exposure. So these points we see, and in secondary survey we mainly see with fast, if there is a fast for the abdomen, pelvic x-ray, chest x-ray for any potential injuries from head to toe that we see. So we'll explore it later. So we'll start with the primary survey. So primary survey, first of all, the thing that comes is A, that is the airway. See, we have to ensure that airway is maintained. So let's go further in it. So the first step in evaluation of this trauma is airway assessment and the protection. So if the patient is conscious and he is speaking in a normal tone or voice, so the airway is normally considered intact. And if the patient has a facial or neck trauma, or there is expanding hematoma, or there is subcutaneous emphysema, or there is noisy or gurgling breathing, or there is neurological deficit with GCS less than, GCS is Glasgow comma scales scope, that is less than 8, it means airway is considered unprotected. So in this field, what we will do, we'll secure the airway with a laryngeal mask airway, or in case if there is orotracheal intubation is required, we'll assess accordingly. So in emergency cases, the airway can be established by orotracheal intubation or the cricothyroidotomy. So if the use of the intubation is precluded or unsuccessful, then we go for the surgical cricothyroidotomy. Okay, so we put a maintain airway by making an airway through the cricothyroid. So next we go I think we should use the break test. So next, if there is emergent intubation is required, what we'll do the rapid sequence induction with what? With continuous, we'll monitor the pulse and the hemodynamics. And in case say there is cervical spine injury, so what we'll do, we can still do orotracheal intubation if the head is secured and if there is inline stabilization during the procedure, or we can go for the nasotracheal route, okay, depending on what's required. So in case the patient neurological sign and the vital signs are okay, they are normal, and there is a risk of expanding hematoma that can compromise his airway, so in that case we'll consider that the airway is unprotected, and then we have to go for the orotracheal intubation, and it becomes an emergency before it becomes an emergency. So that is also important. And another thing, that is in stable patient who have subcutaneous emphysema in the neck, it would be a marker for impending loss of airway, and we should and it should be considered very unprotected. Okay, so subcutaneous emphysema in the neck is considered a danger. Now altered mental status is very common indication, we know, very common indication for intubation in trauma patient. So unconscious patients who have GCS score less than 8 and are not able to maintain or protect their airway, what you will do, try the orotracheal intubation, And if the patient has cervical spine injury, we can still try for the orotracheal intubation by maintaining a manual inline cervical immobilization. How can we do that? Or we can do that by immobilizing the cervical area and placing a support, or we can use a fibro optic bronchoscope if in hospital setting. And the nasotracheal intubation can also be done, and depends on the facial injuries if it's possible. And in case orotracheal tube is not route is not possible at all, we'll go for cricothyroidotomy. Okay. And in small children, the tracheostomy is performed mainly. And so this is mainly how we maintain the airway and different things that we have to take in consideration. One thing to remember is in age less than 8 years, mostly we do tracheostomy over cricothyroidotomy because it can cause airway stenosis, because the cricoid is very small in children than adults. So that is an important point to be taken care of. Next is breathing. B for breathing. So if there is symmetrical breath sounds are present, and so it means there is satisfactory ventilation going on. And absence or decreased breath sounds, it may be due to pneumothorax, it may be due to hemothorax, and that may, if hemothorax is there, there'll be pressure on the lungs, so we need a placement of chest tube in that case. So if we do the pulse oximetry, if we see oxygenation is okay, so hypoxia may be secondary to airway compromise, or due to pulmonary contusion or any neurological injury that has impaired the respiratory drive, and the intubation is necessary now. And also we can measure the end tidal CO2. We call it capnography very commonly, so we can do capnography to see that. And in case of breathing, if there is air moving and getting air moving movement, we can see in the patient, we can see him getting enough oxygen in his blood by oximetry, checking with oximetry the saturation. So then it's fine, and then we can move to the next part, C, circulation. In case there is absence of breath sounds, means there is no ventilation of the lung, so in that case we have to see if there is anything blocking the right mainstream bronchus, or there is any traumatic pneumothorax in that lung. So that we will confirm with the chest X-ray to know the etiology and the guide management. And if oxygen saturation were rapidly dropping, or the patient is showing hypotensive symptoms, and there we can see the BP going down, so we can see that it is more of a case of pneumothorax. And we can go for tension pneumothorax, we can go for needle decompression, and followed by the placement of chest tube. So that is the main management in breathing. Now once the breathing is stable and we have achieved the adequate oxygenation, we can check for circulation. So circulation, mainly what we see is higher shock symptoms. So shock we know is hypotension, tachycardia, oliguria. And why is this all happening? Because of the organ perfusion is decreased. And what will happen then? There will be sympathetic discharge that will cause vasoconstriction in the peripheral, that will cause pale and cold and shivering, sweating, thirsty, apprehensive patient you can see, and impaired blood in the brain will lead to the unconsciousness, and it can be different type. We know the hypovolemic one, in when there is blood loss, depends 15 to 45%, more than 45% blood loss. So the severity we can see accordingly that. So first, and there can be cardiogenic shock. Cardiogenic shock occurs with what? With like cardiac tamponade. There is fluid filled around the heart and it's compressing it, preventing its filling and the circulation. Or there is tension pneumothorax, or neurogenic shock is there. due to the cervical spine cord injury, the spinal injury has occurred. So in hemorrhagic shock, what you will see, there will be collapse of neck veins because there is no low central venous pressure, so there will be collapse of neck vein. While in cardiogenic shock, there will be elevated central venous pressure because of the jugular venous distension, especially cardiac tamponade. And in this, the fluid-filled sac is compressing on the heart, so the blood is in the veins is going backflow, so that leads to the central venous distension. Like in pericardial tamponade, there is shock without respiratory distress. Okay, with tension pneumothorax, there is significant dyspnea, absent breath sounds, and we can see hyperresonance on the side of the tension pneumothorax because of the air, and diminished breath sounds on the opposite side because the mediastinum stinal shift will be there. It will push the other side, right, and will compress the lung. And tension pneumothorax we can see with the trachea diversion. Okay, so what you will do, so in hemorrhagic shock, what you can do fluid resuscitation. First of all, you will start with a Ringer lactate solution or normal saline immediately, and it should be continued until the BP and all the pulse, urine output, they all are stabilized. Urine output we mainly say should be normal till 1 ml per kg per hour. And in the case like there is uncontrolled hemorrhage, permissive hypotension is recommended. So we prevent the further blood loss by awaiting definite surgical repair, but a mean arterial pressure is more than 60 should be maintained to ensure that there is adequate organ perfusion and cerebral perfusion. So that is called permissive hypotension. Now in case trauma, we name what the option will be. You have to go for the 2 large bore IV lines, and that should be 16 gauge and or greater, and if possible we can insert a central venous catheter. We can in children like less than 6-year-old, if we are not able to find the venous access, we can go for intraosseous cannulation of the mainly proximal tibia and femur mainly preferred. So we can, and the transfusion, like in massive blood loss protocol, the transfusion of blood products is 1:1:1 ratio, that is packed RBC, fresh frozen plasma and platelets. And the unstable trauma patient, we rapidly prepare them for surgical exploration. So this should be considered for the assessment of circulation. And for especially for the pericardial tamponade, there is management of evacuation of pericardial space by pericardiocentesis and subxiphoid pericardial window or thoracotomy. And while we are evacuating the fluid, we can continue fluid and blood administration so that cardiac output is maintained. And in the case the person has gone into cardiac arrest, we can do emergency left thoracotomy with pericardiotomy in the emergency department. In the case of tension pneumothorax, mainly we'll see absent breath sounds, tracheal deviation, hyperresonance and distended neck veins. So hypotension and shock will also occur due to decreased venous return to the heart. And so what we can manage is immediate decompression of the pleural space with large bore needle, like needle thoracostomy, which converts the tension to a simple pneumothorax, and then we can place a chest tube. Now in the neurogenic shock or the spinal shock, there is low BP and there is decreased heart rate, bradycardia. So it can also cause circulatory collapse. So patient will be flushed, pink and warm with low central venous pressure. So what we'll give vasopressors like phenylephrine and fluids at filling the dilated veins and restoring the peripheral resistance. So the classic presentation of shock is due to penetrating trauma, mainly when there occurs a trauma case of in the road traffic traffic accidents. So hemorrhage results in hypovolemic shock, and cardiogenic shock occurs due to pericardial tamponade or tension pneumothorax. So steps that we all have to do is to revise again: large pore IV lines, Foley's catheter, fluid and blood administration, and prepare for the immediate exploratory laparotomy for the control of bleed. And the main emphasis in a shock is for fluid resuscitation, because we have to maintain the BP and the perfusion. And the next focus is to control the bleeding, and this can be done manually with the assessment of the internal injuries that need surgical exploration, and then we can control the hemorrhage. Normally we do FAST, which is a FAST exam, which is focused abdominal sonography for trauma. So we in this we see, in FAST we see blood in the pericardial space via pericard synthesis or surgical exploration. We see and in case there is any pericardial trauma, or there is pericardial tamponade, we can go for left thoracotomy, we can go for median sternotomy, and form a transdiaphragmatic window at the time of laparotomy. And if the chest has been opened, the patient, we can still need a laparotomy to assess for abdominal damage, if there is any damage in the abdomen also. And we can fluid administration, blood transfusion, this all will help with the pericardial tamponade. And the main thing I was telling you, FAST, it helps to get check of your abdominal, your pleural, and your cardiac space, okay? And we can see any fluid buildup and help in evaluation of the injuries. Now the next scenario, tension pneumothorax already discovered, immediate decompression with large pore IV catheter in the right pleural space, specifically second intercostal space, mid-clavicular line, and we'll follow it with chest tube placement on the right side. And we can control any bleeding with direct pressure on it for the hemostasis, and manual compression or a tourniquet, depending on which scenario it is. A hemostat or a clamp is not used because it can make injury worse if the placement is blind. And so that's all. And in case of cardiogenic shock, massive MI, all these leading, we can go for EKG, we can check the coronary enzymes, we can admit to the coronary care unit. If they need to be careful, we have to not over resuscitate also. And we can describe the vasomotor shock that occurs due to anaphylaxis, that we forgot to discuss. So in that, what happens? There is inhibition of sympathetic nervous system. So treatment is what? Vasoconstrictors, vasopressors, and the volume replacement we give. Okay. Next up, we have to discuss about the disability. Now, neurological evaluation or disability is an important part of the primary survey, and the key point should be, we should include checking the patient level of consciousness, and the ability to move the extremities and open eyes, and these all can be scored very well with a Glasgow-Coma scale. So Glasgow-Coma scale I learned with EVM 4, 5, 6. So 1, 2, 3, 4, 1, 2, 3, 4, 5, 2, 3, 4, 5, 6. So in this, the fourth one is the best one, the fifth one is the good one, and sixth one is the good one in the respective eye, verbal, and the motor checklist. So first of all, and the worst one is the one. This is the worst one. So this you can remember like this only. If the patient is opening eyes and spontaneously, so it is good, you will give 4 for the eye, and if it doesn't open, then you will give 1. And same thing, verbal, if no sounds, 1. If oriented, having normal conversation, 5. If motor, no movements, then 1, and obeys the command, then it is 6. Now in between you have to remember, right? So in between you can see 2 is with pain, opening eyes with pain, and opening eyes to the voice. So we are remembering from worst to the best. So no response, but goes with the pain, goes with the voice, and opens spontaneously. Now with verbal we say no sounds, then we have some sounds, then we have some words, then we have some disorientation, and then we have normal conversation. Now in motor also we'll go first of all decerebrate, then there is a decorticate, then there is a flexion withdrawal reflex to the painful stimuli, and then localizing the pain, and then obeys the command. So very easy to learn. So 4, 5, 6 EVM. 1 is the lowest, 4 is first is the lowest, 4 is the highest. So open eyes spontaneously with the pain and with the voice, and opens spontaneously. 1 is not opening at all. Sorry. Verbal, not saying anything, all sounds, then give some words, then we can see some disorientation, then the normal conversation. No movement, nothing at all. Then there is a decerebrate, then there is a decorticate, and then there is a flexion withdrawal reflex, and then the person is localizing the pain, and then the person is obeying the command. So decerebrate, decorticate, if we go for decorticate, so there will be the red nucleus, the red nucleus can lead to the flexion of the upper limb, and the rest of the limbs will be in extension. Whereas in decerebrate, there will be everything will be cut off, the red nucleus and everything else. So there will be complete hyper extension in all the extremities. So that is just a short way of remembering it. Now we come to the exposure. Exposure mainly remove the patient's clothing in case of poisoning. If they come with, check for the signs of trauma, bleeding, needle marks, and if there is any snake bite or anything, so we can check for that. So now this is our exposure. Now there occurs secondary survey. Primary ABCD is over. Secondary survey, I have already told you. We are not primary is we are checking for all the basic things that have to be considered. Now secondary survey, we have checked for not immediately life-threatening emergencies, but have to be tackled. So trauma evaluation from head to toe. So we can do complete evaluation for occult injuries. We can do chest X-ray, pelvic X-ray, FAST, Foley's catheter, gastric tube placement, and FAST is very reliable and readily available also for any intra-abdominal pericardial fluid. And it consists of any bedside ultrasound that evaluates for the perihepatic, perisplenic, pelvis, and pericardium for the free fluid. And if there is an unstable patient with positive FAST exam, so that will need an immediate surgical exploration. And if there is a stable patient with positive FAST, then we can go for CT, which is more reliable, and then we may demonstrate the source of bleeding. Like typically it is for like spleen or liver in case of a road traffic accident. So that was our basic primary and secondary survey that has to be done in trauma. So the rest of we can discuss the specific head trauma, we can discuss the specific neck trauma, the surgical danger areas, the abdominal trauma, how to deal with it. So that we'll do in the next video.